Thank you. This is the Hardy Bunch right here. The people who stay to the bitter end. I love you all. You're my peeps. So I want to thank Dr. Carter, Lee Carter, for inviting me to be here today to talk to you about a topic that is near and dear to my heart. For the last 30 years, I have managed a population of heart failure patients, mostly in the outpatient setting. And I've been involved not only with work managing heart failure, but also with national organizations such as the American Heart Association, the Heart Failure Society of America, and the American Association of Heart Failure Nurses. So heart failure has been my life, not just a job. So I'm very pleased to be here to talk to you about this topic. Now my vanity has to go out the window and I have to put glasses on. So, oh, there you are. Good to see you. All right, so I just pressed the arrow. And the best thing to look for in a photographer is a good airbrusher. So I'll just say, I love that picture. I use it every year, everywhere I go. So I recognize that I'm the only thing standing between you and cocktails and dinner and a gala. So I hope that I'll be able to make this interesting for you and informative. Those of you who are PCPs, you are going to see heart failure, and it crosses all areas. It crosses emergency room, it crosses hospice, it crosses inpatient, outpatient, primary care. You're seeing heart failure patients everywhere. So I was asked to kind of apply the topic of heart failure with sudden cardiac death. And so we're going to talk about proactive approaches to preventing it, not reactive. Proactive would be better. We will talk a little bit about reactive, but I think this could not be a better conference title. Proactive medicine in a reactive world. Those of you in the primary care setting, you are in the proactive world. I am 100% in the reactive world. By the time a patient sees me, they already have disease. And my hope is to keep them alive longer. They already have it. You are the proactive people. So I think this could not be a better topic for this meeting. So how do we prevent sudden cardiac death in patients with heart failure? Well, we start by preventing heart failure. That's your job. That's where you come in with risk factor modification. But before I talk about that, I want to talk a little bit about what is heart failure, because I don't know if you've read the most recent guidelines, but it's gotten a little more complicated. It's not a matter of systolic or diastolic dysfunction. It's a bit more than that. We're all familiar with heart failure with reduced ejection fraction, lovingly termed HFrEF by those of us in the biz. And that's an ejection fraction under 40%. If your patient has heart failure with reduced EF that improves above 40%, that's not mid-range heart failure. That's heart failure reduced EF that has improved. If your patient has an EF that is somewhere between 40 and 50%, that's lovingly termed heart failure mid-range EF. So nobody really quite knows what to do with these people because they weren't really studied. Most of us treat them, and most of you probably as well, treat them as if they had systolic heart failure. But I'm going to show you that the guidelines have changed, and actually now there is a different treatment for this population. If they go on to reduce their EF, then their HFrEF. I mentioned HFmrEF. And you should go to a heart failure meeting sometime, by the way. It's very comical. HFmrEF, HFpEF, HFrEF. And then patients who have a preserved ejection fraction are those who have an EF greater than 50%. If their ejection fraction drops, then of course we would say they have reduced EF. And if it drops a little bit, you may say it's mid-range. But for the most part, HFpEF has an EF greater than 50%. You know, when I started doing this 30 years ago, there was either systolic dysfunction or diastolic dysfunction. And that is out the window. That is out the window. I'm going to talk about that in a minute. About maybe 20 years ago, the Heart Association divided heart failure into stages. And the patients in stage A heart failure, I never see because they don't actually have heart failure. They don't even have heart failure yet, but these are your peeps. These are the folks that you are seeing, the people at risk for heart failure. So they decided, let's start treating heart failure before the patient has heart failure. So that means treating their high blood pressure, treating their obesity, their diabetes, keeping up with primary care problems, and maximally treating. Patients in stage B have structural heart disease, but they have no symptoms. They've never had symptoms. They're not short of breath. They're not edematous. They're not fatigued. They don't have symptoms, but they do have structural heart disease. Patients, once they have a symptom, once they develop dyspnea, swelling, orthopnea, then they're stage C, and they can never go back. Once they're symptomatic, they're stage C or above and will remain so for good. Patients with stage C definitely have disease, they have structural heart disease, and they are symptomatic with it. And then patients in stage D are the patients who have more or less end stage heart failure. They're either going to go on to receive mechanical circulatory support, or they may get a transplant or palliative care. Those are limited options, but those are more or less the options for stage D heart failure. What can be the cause of that? I mean, I think we all know a heart attack can cause heart failure, right? We all know that an MI can cause heart failure, but there are many things that cause heart failure outside of coronary disease. Hypertension being the number one next to coronary disease. Chemotherapy that can reduce ejection fraction, rheumatologic or autoimmune diseases that have elevated levels of cytokines can also cause heart failure because cytokines create remodeling in the ventricle. Endocrine, like thyroid abnormalities, diabetes, obesity, familial cardiomyopathy, or inherited and genetic heart disease. And I never thought 30 years ago I would be sending genetic testing on patients, but it's routine now. And we have to be looking at that. I'm going to talk a little bit more about that later. But I want to highlight one particular cause, and that is heart rhythm related tachycardia induced cardiomyopathy. And I'll tell you why this is, I'm so passionate about this, because I'll see a fairly young patient, 40s, 50s, who has a cardiomyopathy with a reduced ejection fraction, and it's not coronary disease, and it's not hypertension, and they didn't have a viral syndrome, and there's really nothing else to account for their cardiomyopathy except for the fact that when I go back into their chart, and I'm in a large health system that has many, many primary care offices, so I can see these patients' charts for many years, and I see that every primary care visit, their heart rate has been 102, 108, 120, 114, 95, 108, 120. This person has a tachycardia-induced cardiomyopathy, and that is a thing. It's a real thing. So I really bring this up because this is so unnecessary. If you are seeing a patient and they are persistently tachycardic in a sinus rhythm, it's sinus tachycardia, but it's tachycardia nonetheless. It is working the heart too hard, number one, and number two, it probably represents increased sympathetic tone, which is norepinephrine, circulating norepinephrine. And circulating norepinephrine is a toxin to the myocardium and contributes to alterations in the myocardial cells to make the heart thicker, to make it stiff, and create fibrosis, as well as arrhythmias. So please, if you have a patient with a rapid heart rate, consider using medications to slow them down, i.e. beta blockers. Patients who have frequent PVCs. If you have a patient who has many PVCs, and I'm not, I see you laughing. He just said don't use beta blockers. And I'm not talking about hypertension. I'm talking about the potential for heart failure. So if it's a persistent sinus tachycardia, slow them down. That's the bottom line. Slow them down. Patients who have frequent PVCs, or patients who have a pacemaker and persistently pace in the right ventricle, because right ventricular pacing initiates the depolarization in the RV, and then it spreads across the myocardium to the LV. So the patient's contraction, instead of being contracting together, the two ventricles together, is right then left, right then left, right then left. And this is dyssynchrony that can actually lead and contribute to worsening heart failure and ventricular remodeling. So I wanted to bring that up only because I have a captive audience of people who give primary care, and I wanted to bring that up to you. Other diseases that we are talking, they're very hot topics in the heart failure circles right now, are infiltrative diseases like sarcoid and amyloid. We need to be looking for this in patients, particularly who have a preserved ejection fraction. I'm going to talk a little more about that. Patients with myocarditis, patients with peripartum cardiomyopathy, patients who have a Takotsubo cardiomyopathy, which is considered a stress, some life stressor that occurs. The patient looks, for all intents and purposes, when they come to the ER as if they're having an MI. They have elevated enzymes, they have EKG changes, and we take them to the cath lab and they have crystal clear coronary arteries. And this is considered Takotsubo cardiomyopathy because the shape of the ventricle is very similar to the shape of the urns that fishermen would use in Asia to capture octopus. So the octopus can get into the urn, but it can't get out. And that's the shape on echo and on cath of the heart when they look at it, like a Takotsubo. And of course, substance abuse, such as alcohol or cocaine. So you can see patients with any of these causes of heart failure. So much has changed in 25 years. These two little babies are these two young men now. So what I want to say is I still see notes that say if a patient has a preserved ejection fraction, they have diastolic heart failure. And it's just not that simple. It simply is not that simple. And if someone is saying to you, oh, this guy has got a preserved ejection fraction, he has diastolic heart failure, they're about 25 years behind the times because it is much more broad than that. Way back when I started, we thought, well, about 75% of patients had systolic heart failure and 25% had diastolic heart failure. And that's not the case. It's a good 50-50 split. And I bet there's a lot of preserved ejection fraction out there that we don't even catch. We don't even recognize it for what it is. So how do we know heart failure with preserved ejection fraction? Well, this was created by Michelle Kittleson, and she's a pretty smart lady, cardiologist, who gives a point system. So if your patient has, if they're overweight, and if they're on 2 or more antihypertensives, give them 2 points if they're overweight, 1 point if they're on an antihypertensive. If they have AFib, give them 3 points. If they have pulmonary hypertension, and you would see that in what's usually called the RVSP on the echocardiogram, and that's the right ventricular systolic pressure, the pressure that the right ventricle must press against to get the blood through the pulmonary vasculature, can be a surrogate for pulmonary hypertension. If that's the case, give them 1 point. If they are elderly, and I kind of take over 60, let me tell you a short story. One time I stood up at years and years and years ago, probably 20 years ago, at a heart failure meeting, and I gave a case study of a patient who was 65, and I made the mistake of calling that patient elderly. And at the end of my talk, people, there was microphones set up for questions, and people lined up to berate me for calling that patient elderly. So I'm very careful about it. And you know what? I'm right next door to that now. So the older I get, the younger that looks. But so if you're concerned, well, does this patient has heart failure symptoms, they have a normal ejection fraction. Is this heart failure with preserved EF or not? Well, you can use this system and look at it. If they have these comorbidities, then you can be pretty sure they have preserved EF. When are you going to see this? You're going to see this in hypertensive patients. Patients with amyloid often have a preserved ejection fraction, but they have heart failure symptoms. You may see this in patients with sarcoid who have a preserved ejection fraction, but they have heart failure symptoms. You may see this in hypertrophic cardiomyopathy. And it can get even deeper into the weeds, such as looking at specific parameters on the echocardiogram to diagnosis as heart failure with preserved ejection fraction. They may have an elevated natriuretic peptide. They may have some sort of hypertrophic cardiomyopathy. So just because the patient has a normal ejection fraction, don't assume they don't have heart failure. because they do. But what is the etiology of that heart failure? It's not as simple as heart failure with reduced EF. We can say, well, they have a reduced EF. But patients with preserved ejection fraction and heart failure symptoms can have a cadre of things going on besides just cardiac contractility issues. So let's move over a little bit to sudden cardiac death. The definition of sudden cardiac death: the sudden unexpected termination of cardiac activity associated with the loss of consciousness, the loss of spontaneous breathing, and the loss of circulation that occurs within 24 hours of the onset of symptoms. And this may also, and it's of a cardiac origin. This may be the first symptom that the patient has, is sudden cardiac death. It's usually not attributable to just one single event or one single item, but it's a group of mechanisms that lead to rhythm disturbances, most commonly either ventricular tachycardia, ventricular fibrillation, but hemodynamic failure is being seen more and more, such as pulseless electrical activity and asystole. So in heart failure with reduced EF, it's more common that the patients are going to die of a cardiovascular death, and more of them will die of sudden cardiac death. It's about 30 to 50% of the cardiovascular deaths. In patients who have a preserved EF, about 50 to 70% of those patients are going to die from a cardiovascular death. And of those patients who die of a cardiovascular death, about 35 to 40% of them will be sudden death. And then about 20 to 30% of these patients will die of heart failure itself. So it is more prominent to see non-shockable rhythms, less VFib, VTAC in patients who have preserved EF. You're more likely to see asystole or PEA, but it's very difficult to assess what these people really die from because the definition of HFpEF is variable among the different clinical studies. The definition of sudden cardiac death is different among these clinical studies. So it's really, there's not one set criteria that every study has followed. So it's apples and oranges when you're comparing these different clinical trials. But one thing I do want to say is that when someone has a sudden cardiac arrest episode outside of the hospital, less than 20% of those people are going to get a rhythm restored. And if they do get a rhythm restored and they get it to the hospital, less than 10% of those people are going to actually make it to hospital discharge. So it's very low survival, very high morbidity. Most sudden cardiac death and heart failure are due to arrhythmias, but more and more, as I mentioned, patients are having other rhythms that are causing sudden cardiac death other than VTAC or VFib. People who are at the highest risk for sudden cardiac death are people who have had an episode of sudden cardiac death already one time, or if they have a reduced EF below 40%. Now, this was the Oregon Sudden Unexpected Death Study, SUDS. Cardiologists, they always have an acronym for everything. So heart failure, they looked at people who, about 650 people who had an out-of-hospital cardiac arrest. And of those patients that they were able to get the results, if they knew their cardiac function, in other words, they reviewed them. And of the patients who had this out-of-hospital sudden cardiac death, those who had a reduced EF, about 45% of those were a shockable rhythm, like VTAC or VFib. But they had low survival to hospital discharge. But this population with an EF less than 35% is able to get an ICD is indicated. So this population definitely can get an implantable defibrillator. But what about patients? They called it borderline HFpEF, but this is the mid-range, 40 to 50%. About half of those patients had a shockable rhythm. They had a little bit better survival. So that begs us to wonder, is there a subgroup of patients who have a mid-range EF who should get an ICD? Do we know who they are? What would we look for? What would be the symptoms? What would be the characteristics that would call for an ICD in those patients? And the answer to that is nobody knows, not right now. There was a study, the Made It SCD trial, that was stopped early because of low enrollment. But there may be a subgroup of patients with mid-range EF who should have an ICD. And then of those with a preserved EF, fewer of them had VTAC or VFib. That was a shockable rhythm. They had a low survival rate because PEA, asystole have a lower survival than a shockable rhythm. I mean, at least a shockable rhythm, right? You can shock it, but if PEA, have you ever seen PEA? Been in a code cardiac arrest with PEA? It's the strangest situation ever. There's a beautiful heart rhythm right there, and the patient's dead as a doornail. It's very, very odd. So there need to be further studies in patients who don't have reduced EF to see if there is a subset that should receive an implantable defibrillator. So as I mentioned, these are all clinical trials for heart failure. I think over here is the ROUSE trial, the CHARM trial, and ending with PARADIGM. This is from 1995 to 2011. And this incidence of sudden death has fallen in patients with heart failure, probably because the drugs are so much better. And all treated cardiac arrests in patients with heart failure with reduced EF have dropped considerably. And this is ended in 2000. And we've even got better drugs since then. But it's from 1979 to 2000. The incidence of cardiac arrest has declined in patients with heart failure. Ventricular fibrillation specifically has declined. Again, the drugs are better. Now we have defibrillators, but patients who have asystole or pulseless electrical activity, it's pretty flat. It hasn't improved. It hasn't gotten better. So those rhythms are still there. And note that the degree of ventricular fibrillation is not that far behind those of asystole and PEA. And survival is much lower in this population. So patients are having less shockable rhythms, but they're dying from rhythms that are highly morbid. What are the phenotypes for sudden cardiac death? Well, those who have coronary artery disease, I think we all know, patients who have an acute MI, or patients who have had an acute MI in the past, coronary vasospasm, coronary dissection, and any form of heart failure. Patients, even if they have a preserved EF, especially with coronary disease, are at higher risk for sudden death than patients who don't have any heart failure. What about under cardiomyopathies? Patients who have reduced EF with a dilated, even a non-ischemic cardiomyopathy, that is a phenotype for sudden cardiac death. Inherited channelopathies like long QT syndrome, which is considered a cardiomyopathy. Hypertrophic cardiomyopathy, which is getting a lot of press right now in heart failure circles because there's a new medication, Camzyos, for the treatment of hypertrophic cardiomyopathy. In the past, we used either alcohol ablation or cardiac myectomy, but now there is a drug for the treatment of this. So it's getting a lot of press right now in heart failure circles. Patients with an inherited cardiomyopathy, like a genetic variants, and that also is getting a lot of press in cardiology circles now, and they're pushing for genetic counseling and genetic testing on these patients with unexplained hypertrophic cardiomyopathies. Congenital heart disease, sarcoidosis, which tends to cause ventricular arrhythmias or conduction delays, conduction blocks, and amyloid, which this is light chain amyloid, which is more likely to cause PEA. In patients with heart failure with preserved EF who have sudden death, sudden cardiac death can be a tachycardia or a bradycardia. And if they do have a tachycardia, then that patient may be indicated to receive an ICD. If they have EMD or cardiovascular collapse, that's just life support medications. If they have hypertrophic cardiomyopathy or an infiltrative cardiomyopathy, in certain situations, an implantable defibrillator is indicated in those patients. But if they have just other comorbidities, the question is, should some of those patients receive an ICD? And that is being looked at right now. So in HFrEF, patients are more likely to die of a cardiac cause. In HFpEF, patients, they do die from a cardiac cause, more so than the general population, but they're likely to die from other causes as well, more so than patients who have reduced EF. So what are the comorbidities for sudden cardiac death? Your patients who have diabetes, which can promote fibrosis of the myocardium, inflammation of the myocardium, patients who have ventricular hypertrophy, which can stretch the myocardium and also cause fibrosis of the myocardium, patients with autonomic dysfunction, patients who have alterations in their RAS system, and sleep apnea, which is closely associated with heart failure. It's thought that at least 50% of the people with heart failure have sleep apnea. So that is definitely something that you need to examine in your patients. Yeah, I ask every patient 3 questions. Do you snore? Do you feel refreshed when you wake up? And do you have daytime sleepiness? And if they say yes to any of those, they should get a sleep study, especially in the presence of heart failure. The pathophysiologic mechanisms of sudden cardiac death. I mean, you ever think about what exactly is happening in the myocardium that is causing the heart to act this way? It doesn't just shake, doesn't just start shaking. What at the cellular level is happening in the heart? Well, in patients who have electrophysiologic causes of sudden cardiac death, it's mostly reentry mechanism, repolarization, or triggered activity. And I'm going to talk about those in just a second. If it's myocardial ischemia, then it may be myocardial infarction, atherosclerosis, coronary dissection. If it's inflammation or a mechanical issue, stretch and fibrosis can change the electrical conduction in the myocardium. So let me talk for a minute about abnormal automaticity. You know, it's the sinus node that drives the heart because the cells of the sinus node rest closest to the threshold of the action potential. That's why the sinus node drives the heart primarily, right? As you move down the heart, the cells move farther away from the threshold, and that's why they don't reach threshold to cause heartbeat, an electrical activity. But abnormal automaticity occurs in cells that have an altered resting membrane potential. They rest closer to the threshold, closer than the sinus node, so that they take over pacing the heart because the cells are ready to depolarize more so than the sinus node. One of the most common causes, though, is reentry. So if you think about it, you may have fibrosis. If myocardium fibrosis, which it does in heart failure, we know that. The myocardium gets thick, it gets fibrosed, caused by angiotensin II, norepinephrine, and aldosterone, all contribute to fibrosing. But it's not consistent fibrosis throughout the entire myocardium. Every cell is fibrosed. It's patchy. Or if a patient has had an MI, areas of scar are patchy. So there's healthy tissue right next to scar tissue, or healthy tissue next to fibrosed tissue. So as the electrical depolarization wave is traveling through the myocardium, it passes through the healthy myocardium, no problem. But in the areas that are either fibrosed or scarred, that depolarization wave pauses. It slows down. Oops. It slows down. So it goes on to depolarize this area over here, but then the impulse can travel backwards and go back up to where it came from. And then it can start circling around. So a depolarization depolarizes this area up here, and then this area down here. And it goes back and depolarizes up here, and then back down here. So the wave of depolarization is not even when there are patches of fibrosis or patches of scar. And that can lead to a re-entry, because by the time that late depolarization gets through the scar area, the rest of the myocardium is ready to depolarize again. And so now it's getting depolarized late from that wave of electricity that came through the patchy area. I don't know if that makes sense. But it's the same depolarization that goes around and around and around. Or triggered activity, which is also very common. And you've heard of R-on-T phenomenon. The action potential of a myocardial cell, if it is stimulated during repolarization when it is unstable and not ready to depolarize again, can depolarize in a very erratic and abnormal fashion. And that's what you see here. Or if it's later in the repolarization, it can cause another depolarization. This is the most common cause of arrhythmias in the ventricles. And that's what we see in heart failure. That's what we see in patients with coronary disease and ischemic disease. So now if it was this easy, what's that? Not even a giggle. Not even a, what time is it? Oh my gosh, it's cocktail time. All right, this is a tired crowd. So what are the risk factors in your patients? In your patients who have ischemic disease, for those who have HFrEF with an EF under 35%, and they can get an ICD 40 days after they've had a myocardial event. Patients with mid-range or preserved EF are not indicated for a defibrillator. So those patients just try to maximize medications. There was some thought that statins might help prevent sudden cardiac death in patients with preserved EF, and that does not appear to be the case. If patients have a non-ischemic cardiomyopathy, again, for patients with reduced EF under 35%, an implantable defibrillator is indicated after 90 days of good therapy, maximizing their heart failure therapy. If patients have inherited channelopathies like long QT syndrome, if patients have hypertrophic cardiomyopathy, and I'm going to outline some of the things that you may see if the patient has, that they would be indicated to receive an ICD. So how can you know? How do you know if your patient is at risk for sudden cardiac death? There are risk scores. Most commonly in heart failure, we use the Seattle heart failure model. It can tell you how you can reduce mortality by adding medications, by adding devices like defibrillators. There is an Italian risk score tool that we don't use too much. And then the European Society of Cardiology has developed a hypertrophic cardiomyopathy sudden cardiac death risk calculator. So 30 to 70% of sudden cardiac death in clinical trials of heart failure with reduced EF are not prevented by an ICD. So asystole, PEA, that is not treated with an ICD, especially in patients with advanced heart failure. But this is a very important point I want to make to you right here. Patients who are New York Heart Association functional class 1 and 2, you know what I mean by that, people who either have no symptoms or very mild symptoms. An ICD can decrease sudden cardiac death in that population by 60 to 70%. But if the patient has more advanced heart failure, implantable defibrillators decrease sudden cardiac death by considerably less. So let me translate this to you. This is the patient sitting in front of you who has a reduced ejection fraction. They're feeling pretty good. They're not very short of breath. You have them on the 4-pillar medications and they're doing well. Maybe they've even returned to work. And so in your mind, you say, well, he's doing really well. He doesn't need a defibrillator. That is the person who will most benefit from a defibrillator. Patients who are late class 3, patients who are class 4 are going to probably die from their heart failure. And in fact, there's data to show that. So the purple here is sudden cardiac death. New York Heart Association class 2, New York Heart Association class 3. Those people are going to die of sudden death more likely. The patients with New York Heart class 4 are going to die from their heart failure. So I say this, if the patient's looking pretty good and they're feeling pretty good and they still have a reduced ejection fraction despite optimized medical therapy, that's the person whose life will be saved by a defibrillator. So what are some proactive approaches to prevent sudden cardiac arrest in heart failure patients? Well, the guidelines. I don't know if you've had a chance to look at the guidelines, but now there are 4 medications that are standard. So if it's a patient who is stage A, someone you are seeing who doesn't actually have heart failure yet, you know what to do. Treat the blood pressure, treat the diabetes, help the patient lose weight, et cetera, et cetera. If the patient is stage B, we do recommend, gosh, there's a small print up here, angiotensin converting enzyme inhibitors. You may say, well, what about ARNIs, angiotensin receptor neprilysin inhibitors? And you say that up here after a long day sitting in a chair. That's a mouthful. ARNIs were not studied in patients who have no symptoms. So remember, stage B are people who have structural heart disease, coronary disease. They may even have reduced EF. They may have hypertrophic cardiomyopathy, but 0 symptoms. ACE inhibitors are still appropriate for those patients, or an ARB if they can't take an ACE inhibitor, beta blocker, and an ICD. even if they're not symptomatic. That's an important point to make. If the patient has a reduced EF and they are stage C, the number one recommendation in the newest guidelines from 2022 is an ARNI, sacubitril valsartan, Entresto. That's the number one recommendation if the patient can't afford that or can't get that. And believe me, we have gotten very, very clever about being able to get medications for patients. Whoever thought that would be our job, but it is. More and more, we have to be very clever to get medicines for patients. So number one is an ARNI, ACE or ARB, beta blocker, MRA, spironolactone or eplerenone, and SGLT2 inhibitors are key, have shown reduced mortality and have shown reduced hospitalization in heart failure patients, regardless of their EF. So those are the 4 drugs that we're using, and diuretics only as needed. If their EF remains under 40%, where else can you go with that? Well, if they're African American, the AHEP trial showed that the addition of hydralazine and isosorbide also decreased mortality. But you know what? The people in that trial self-professed to be Black. There's no genetic test, no DNA that said that person's Black or not Black or how white. So I just will tell you personally, and I know other heart failure specialists, so if my patient remains hypertensive, regardless of their skin color, and they need further blood pressure lowering, a lot of us tend to add hydralazine and isosorbide, because again, this was not looked at in any other population other than African Americans who professed African American. But again, there's no blood test, there's no DNA, there's nothing that makes those people different, makes us different inside, right? Also, if the patient is New York Heart Association class 1 or 2 and their EF remains under 35%, an implantable defibrillator, and if they have a broad QRS, usually greater than 120 milliseconds, but the people who will benefit the very most from biventricular pacing are the people with the wider the QRS. If you can drive a truck through it, they're going to get a lot of benefit. So 150 milliseconds, those are the people who get the best benefit from resynchronization therapy. And then I can't even see what that says. Oh, and then if the patient goes on stage D, mechanical circulatory support like a VAD, cardiac transplantation, palliative care. Now, there are some other new medications. Has anyone here prescribed ivabradine? It's fairly new medication. This is a drug that slows the heart. There's data that shows in patients with systolic dysfunction, patients who are class, I think it's 2 or 3, and in sinus rhythm. This is not for patients with AFib, with rapid rate. Patients in sinus rhythm, ivabradine is a drug that slows them down. Corlinor is the brand name, that slows down the heart rate. And if this patient has a consistently elevated heart rate, and I have used this in those patients who have persistent sinus tachycardia, despite maximum beta blocker dose. Digoxin is not indicated in those people. But this drug, ivabradine, can slow the heart. It works on the ion channels to slow the heart without dropping blood pressure. Doesn't change anything except slowing the heart rate. And I've seen very good success in patients who've had improved EF who had persistent sinus tachycardia. Vericiguat is also a new one. This is promotes cyclic GMP, increases endothelial function, vasodilation, and decreases fibrosis. So it has decreased mortality and decreased hospitalization in heart failure patients. So if you have a heart failure patient, you can't get them on the 4 guideline drugs because maybe their heart rate's too slow for a beta blocker. Maybe their renal function is such that you really can't start an ARNI or an ACE or an ARB. You can add this drug in its place. So it's kind of a niche drug. It's a new one. It's a niche drug. I don't have a lot of patients on it, but it is there to add to your armamentarium. I have a patient who's just consistently dizzy on beta blockers, insisted he couldn't take them, and so he is on Vericiguat, tolerating it great. So I know he's getting additional benefit. Digoxin is still there. Mostly we use it if the patient has AFib and they're in a rapid rate. We want to control their rate and can't get it down with beta blocker alone. Polyunsaturated fatty acids have shown some benefit. and potassium binders. So if you have a patient on spironolactone or eplerenone and they have consistently elevated serum potassium level, you can use these potassium binders like Lokelma. I forget the name of the other one. Can't remember the other name, Lokelma, that can bind the potassium so that the patient can continue to take their spironolactone or their MRA. One thing to watch out for with these particular drugs, though, is that they don't just bind potassium. Sometimes they bind the other medications that the patient is taking, and it goes out through the GI tract. So it has to be taken completely separately from their other medications. Now, what about mid-range EF? Diuretics if needed, but look here, SGLT2 inhibitors are the #1 drug recommended because SGLT2 inhibitors are the only drug that has been shown to benefit this population in mortality and hospitalization. If they are symptomatic, you want to add ACE inhibitor, ARB, or ARNI, MRA, beta blocker. Most of us go ahead and do that anyway. The patient's ejection fraction is between 40 to 50, but start with an SGLT2 inhibitor. And the same is true of HFpEF. If a patient has heart failure, they have a preserved EF, the #1 drug on the guidelines is SGLT2 inhibitor. Specifically, the two that are out are dapagliflozin and empagliflozin that we're using right now. But then you can add the other drugs. Notice beta blockers are not particularly on here. Keep in mind that in patients who have a preserved EF, but may have a stiff ventricle, they can't fill that ventricle more full for better cardiac output. It's a stiff ventricle. And so if we then slow their heart rate down, they really can't improve their cardiac output when they're active, when they're walking or trying to do something. So we can increase their fatigue if they are over beta blocked. But ARNI is indicated or ARB. And now, what are some things that we do to treat patients? How beneficial are they? Well, drugs or surgical procedures that prevent MI, how much do they help prevent sudden cardiac death in heart failure patients? Statins, no benefit. Antiplatelets and anticoagulants, no benefit. Coronary bypass graft surgery in patients who have reduced EF and coronary disease has shown about a 25% decreased risk of sudden cardiac death over years for patients with reduced EF. Drugs or devices that can prevent remodeling, that will prevent sudden cardiac death. ACE inhibitors have not been found in patients who just have a reduced EF, has not been found to decrease sudden cardiac death. But if the patient is post-infarct and they have left ventricular dysfunction, then it does decrease sudden cardiac death. Beta blockers in patients with reduced EF, post-infarct LV dysfunction, about 25% decreased risk in post-infarction LV dysfunction, and a great decrease in risk of sudden cardiac death in patients who have reduced EF. So benefit from beta blockers, most definitely. MRAs, there's about a 35% decreased risk if they're also on a beta blocker. By the time MRAs were studied, patients were already on ACE inhibitors and beta blockers, and MRAs were an add-on. So definitely getting the patient on all of the medications can decrease the risk of sudden cardiac death. Even Entresto, neprilysin inhibitors, sacubitril, valsartan, there's about a 20% decreased risk overall and about a 50% decreased risk in patients who have an ICD. So it can benefit the patient, and CRT has been found to benefit patients to decrease about a 50% decreased risk in patients class 2 or 3. But patients who are New York Heart class 4 and you put in a biventricular pacemaker, they're too far along. They're too far along, and this isn't going to prevent sudden cardiac death in those patients. What about implantable defibrillators? Well, about a 60 to 70% decreased risk in patients who are New York Heart class 2. So in other words, the more well patient that you see is the person who is most going to benefit from an ICD. And then what about antiarrhythmic drugs? No, they actually increase the risk of lethal arrhythmias. So this is the angel, the one that got away, damn defibrillators. There you are. You're still here. Good. Maybe we should have done the cocktails before and then do it. It would have been good. What about SGLT2 inhibitors? Some of the newer drugs. SGLT2 inhibitors have been found to decrease the risk of composite outcome of serious ventricular arrhythmias, sudden cardiac death, resuscitated cardiac arrest in patients who have a reduced EF. So dapagliflozin was studied, and when it was added to baseline therapy, beta blockers, ARNI, MRAs, does decrease the incidence of sudden cardiac death. What about patients, though, with preserved EF? Mortality rates in HFpEF are higher than the general population, but not as high as patients who have reduced EF. But dapagliflozin, which is, oh gosh, I just went blank. Yeah, Farxiga, dapagliflozin, has been found to be beneficial to prevent decrease CV death, heart failure events, heart failure hospitalization, and all-cause death in patients with mildly reduced or reduced ejection fraction. So SGLT2 inhibitors, hence, are at the top of the list for patients with mid-range and patients with preserved EF. Now, I want to talk just for a second, because that's all I got, about hypertrophic cardiomyopathy. Because patients with hypertrophic cardiomyopathy in the past either underwent alcohol ablation, where they literally inject alcohol into an artery that perfuses the septum, and it causes it to shrink, or underwent myectomy, where that bulging portion of the septum is literally cut off. Those were the two options. But there's a new drug out, Camzyos. It's an myosin inhibitor. So it decreases the number of actin and myosin cross bridges, and that decreases the size of the hypertrophy. And that's only indicated for patients who have serious left ventricular outflow tract obstruction. As you can see, right where the aortic valve is, right here, this can block flow out of the heart. These patients can have sudden cardiac death. And these patients may or may not have a reduced ejection fraction, that it's variable. But if they are at risk for sudden cardiac death, they would be indicated to receive a defibrillator. So what are the things you would look for? And AFib, by the way, is the primary arrhythmia that these patients suffer. So a defibrillator is a shockable treatment. So it's the most common cause of death in hypertrophic cardiomyopathy. So the risk factors, if the patient has two or more of the following, you would consider putting an ICD. And what you would see on this patient's echo is it would say asymmetrical basal hypertrophy, basal septal hypertrophy, asymmetrical basal septal hypertrophy. I'm sure you've probably seen that. It shows up on a fair number of echoes. And you want to know if the LVOT, left ventricular outflow tract gradient, is high. You want to know how many millimeters of mercury pressure is going through that outflow tract. So if the patient has non-sustained VTach on monitoring, you put a Zio monitor on the patient and they have 3 or more consecutive ventricular beats at a rate of 120, lasting under 30 seconds. So short salvos of brief VTach, that's one thing. If they have severe LVH, where the outflow tract is obstructed and there's a high gradient of blood flow out of the heart, that's another reason. If they have a blunted systolic blood pressure response to exercise, meaning they exercise and their blood pressure does not, you put them on a treadmill, their blood pressure does not go up, or you put them on a treadmill and their blood pressure goes down, that means that with vigorous activity, this outflow tract is blocked even further than it is at rest. If they have a family history of sudden cardiac death, I had a new patient a couple of months ago with septal hypertrophy, and he told me the story about 2 uncles who died quietly in their sleep. I said, So we sent genetic testing. We wanted to keep a very close eye on this patient. If a patient has had unexplained syncope, that is another reason. If they have an aneurysm in the left ventricular apex area, if they have reduced ejection fraction, enhanced late gadolinium enhancement on contrast cardiac MR, or if they have, interestingly, if they are younger. because the incidence of sudden death with hypertrophic cardiomyopathy is actually lower in people over 60. Yay, we get something. If your patient has hypertrophic cardiomyopathy and they have 2 or more of these things that I have just named, they would be a candidate for an implantable defibrillator, and you should refer them to cardiologists for further evaluation. So, okay, proactive medicine in a reactive world. And what this says is it just me, or is it a bad idea to eat at a place that prints CPR instructions on their placemats? People are going to continue to eat this kind of junk, right? But you're the ones who are there on the front lines to try to prevent their risk factors from getting worse. And this says, I eat cheap, greasy food so I can save for my cardiologist bills in the future. Job security. All right, that's all I have for you. You made it through. Yay! We have a couple of minutes for questions before cocktails. Okay.
Josh, there you go. You're good to go. Thank you. It's a wonderful lecture. Now, can you make a comment on the role of chronic stress, chronic anxiety with cardiomyopathy? And what is the role of the stress management as a part of proactive medicine in the prevention of cardiovascular disease?
Okay, let me answer the first one about stress. Stress alone, I don't think is going to cause cardiomyopathy, but if a patient has persistently elevated heart rate, if they have such stress that they have neurohormonal activation that is persistent, such as norepinephrine, adrenaline circulating all of the time, then that can contribute to developing cardiomyopathy. If a patient, though, is stressed, for instance, a patient will say, I just can't sleep. I just wake up from my sleep. I'm so worried. Well, what they're really having is PND. So the question is it anxiety or stress because they're out of breath, they're not breathing? Or is it just stress, and will stress alone cause cardiomyopathy? There usually needs to be another substrate. Right, and that's yeah, norepinephrine is a toxin to the myocardium. There's no doubt about that. No doubt that it probably plays a role. But I think anxiety alone, now if they have elevated levels of norepinephrine that consistently circulate, yeah, it could be. That's the patient with persistent sinus tachycardia. Yeah, Takotsubo is usually associated with an acute event, the death of a loved one, the death of a spouse, some acute event that has, and nobody really understands it completely, but I think you're probably right. I think it's release of adrenaline, norepinephrine. Right. I understood most of that, but I agree. I mean, I agree. Persistent tachycardia, certainly the heart is a muscle, you're right. And exposure to norepinephrine and ongoing tachycardia, which, as you say, it's a muscle. It will get bigger over time. Absolutely. That's right. That's right. I can't say that I've seen anxiety alone to cause that, chronic anxiety to cause that alone, but I wouldn't rule it out. I mean, I wouldn't rule it out. The bottom line is treat the patient, right? Treat not only, and you know, there have been studies looking at anxiety and heart failure, anxiety as well as depression in heart failure, and mortality is higher in patients who have chronic anxiety and depression for multiple reasons. Some of it meaning self-care, they don't take their medicines, they don't seek help, but some of it may be, related to heart rate, et cetera.
Regarding HOCM and the myosin inhibitors,
Yeah.
how is it targeting the IBS and specifically, and if that's not possible and it's more systemic, what kind of side effect profile does that have?
Yeah, that's a good question. I have to confess, I haven't used it myself. I check every patient's outflow tract and I have not found anyone, and they have to have an outflow tract gradient of 50 or more. So what this does, and a preserved EF for this drug, they must have an EF over 50. So if you're right, it can, by altering the actin myosin, can also decrease the ejection fraction by decreasing the strength of contractility. And if the patient's EF, I think it's if it drops below 50 or 45, you stop the drug or you cut it back and you wait to see if the heart improves in function again, and then you can restart it. So those patients get an echo, I want to say every 2 months. So I don't know, it's magic how it affects the septum, but it decreases the strength of contractility, and increased contractility, like with exercise, blood pressure drops, less blood is getting out of that outflow tract because the septum is closing in on the aortic valve and less blood is able to flow out. So by decreasing contractility, more blood can flow out, and it does decrease the outflow tract gradient. But they do watch the EF. If it goes down, you stop the drug.